Afternoon, everyone. My name is Sarah Manyi, and I'm really delighted to welcome you to this hybrid event, Optimizing Africa's PEP Response, Research to Reality. I am representing the South to South Learning Network and Insight to Implementation initiatives, and we're really about reimagining HIV prevention. And as you can see here, we've tried to echo that sentiment by reimagining this space. Those of you who were here earlier today would have seen that this was probably where you had breakfast. And so we've tried to make sure that everybody can have a break from the conference and just share this lovely space outside. So just to make sure that we don't run out of time, I'm going to ask Professor Peter Godfrey-Fawcett to welcome us to this event and to share with us an overview of the event's objectives. Now, I know everybody probably knows Peter, but I do just want to share that he's been working in this field for almost as long as I've been alive, I think. He's been a scientific advisor to UNAIDS. He was the chair of the Global Fund Technical Review Panel, and importantly, one of the guest editors of the PEP in Africa supplement. So thank you, Peter.
Sarah, thank you very much. And big welcome to you all. Thanks for the introduction. Just certainly someone at the reception yesterday said the great thing with old people is they should retire so young people can take their place and take their salaries and so on. Well, I have more or less retired, but nonetheless, it's been a great pleasure to be part of this process that we've been going on. Welcome to those of you who've taken the time out of the conference here in Kigali to be in the room, and a big welcome to the large number of people who are joining online, which is part of the idea of being hybrid, is to allow us to get to a wider audience. I want to start quickly by just saying thank you to Genesis and Sarah, to the South-South Learning Network, to the Journal, the International AIDS Society, and of course to Gates, the Gates Foundation, who funded this whole process. This event is definitely a stepping stone. If I was Churchill, which I'm certainly not, I would say that this is not the end. But it's something that he goes on about, it's not the beginning of the end, but it's the end of the beginning. Because PEP, of course, has a long way to go. But this has been a really exciting process to try to get to where we are today with the launch of this supplement on PEP as it applies to Africa. Obviously, the HIV prevention field, as we hear all around us in this conference, is evolving rapidly, evolving options for prevention, an evolving epidemiology of HIV, and an evolving landscape, particularly funding. And thank you, Yvette, for pointing out to me that the landscape evolved even further last night when there's optimistic news that the White House has said that PEPFAR will not actually be included in the budget cuts. So that's extraordinarily good news. It still has to pass through Senate, but nonetheless, I think that's the best news that we could possibly get at this conference, and probably even more important than this meeting, possibly. So about 18 months ago, we decided to explore what the situation was with PEP in the context of African HIV epidemics, to see where it would go. And at the time, when we put our heads together, we were aware with the Gates Foundation of about 4 projects in Africa that were really working on PEP, which just shows how ignorant we were. So the journal issued a call for abstract submission, and we got a group of about 18 different research groups who came to a workshop in Cape Town just over a year ago, presented their ideas, and have then worked tirelessly with the editorial team and with the guest editors. So at this stage, I'd like just to introduce the other guest editors, Julie Fox and Euphemia Sibanda. And the 3 of us have tried to steer the process. And as you all know, steering a journal supplement is quite a lot of hard work and not very well rewarded, but our reward is in seeing a fantastic supplement come out, free open access online. You can just click to get there. And there are a full 18 research papers in that supplement from all over the East and Southern African region. So we've been really impressed by what's come out of it. And the journal includes nice examples of innovative approaches, largely pilot schemes in different settings and different ways of delivering PEP, but really interesting approaches, some of which we'll hear about later on today. It then includes reviews of programmatic and national programs, often showing the challenges that there are in delivering things at scale and in collecting data on it. And then it has some more upstream things about how on earth we're going to tell whether new PEP products actually work, because it's very difficult. You can't do a randomized trial. That will never happen. There's never been a randomized trial of PEP. And so ways of seeing whether we could go from 28 days to shorter, perhaps to a single dose eventually, but how would you know whether it was working? What are the regulatory implications? And what's the sort of space around where PEP would be most useful from a health economics point of view? And all those are included in this supplement. So what about the way forward? Our idea throughout both the Cape Town meeting, which was an SSLN meeting onto which the journal supplement was tacked, if you like, is all about engaging with the different people who need to be in the room to have the conversation about where PEP will be. And that's community and what they want and what they need and what choices are needed. It's government, because in the end, government is the one that has the responsibility. It's policymakers in government outside and internationally. It's researchers, of course, and it's funders. And we've tried both in that meeting in Cape Town and again here to have representatives from all those parts in the mix. And the journal supplement, we hope, will be a catalyst to stimulate conversation, to push the agenda forward in order that we know what the priorities for PEP might be in the context of the current and future HIV prevention landscape in Africa. So that's why we're here today. Thank you for coming. And with that, I'd like to pass back to Sarah and say thank you very much.
Thank you so much, Peter, for opening for us. Michelle, I'm going to call on you. Michelle Rudolph is a technical officer at WHO, where she leads the ARV-based prevention work, including the development of policy and guidance on PEP and PrEP. So Michelle, over to you.
So thanks so much, Sarah. And it's an honor and a little daunting to go after Peter. Peter is not, well, Peter is older than me, but he didn't start working in this field when I was born. But I have worked with Peter for about 15 years. So it is a privilege to be here with Peter. So I just, on behalf of WHO, I wanted to just say a few things. This, the meeting that was, that was had in Cape Town about a year ago followed WHO recent guidance on PEP. And I just wanted to kind of set the scene a little bit with a few words. I'm going to try to take 5 minutes. But as we all know, PEP is one of the oldest intervention tools and most underutilized tools that we have. It's been around since the 80s. And WHO in the last 2 years has tried to reinvigorate PEP. So just to really say, you know, WHO has updated their guidance to make it really clear after looking at PK modeling that PEP should be offered as early as possible, ideally within 24 hours and no later than 72 hours. WHO recommends a 3-dose regimen for PEP for 28 days. And hold on. And our WHO came out with our first guidelines on PEP in 2014, and that's continued through 2024 when we updated our new guidelines on the implementation of PEP in community settings and for task shifting. And really, our idea for rethinking post-exposure prophylaxis in our guidelines from last year was that there's been low knowledge of PEP among healthcare workers, underutilization, limited PEP delivery points, high cost in the private sector, an unfortunate late start, and limited guidance on PEP to PrEP or use of PEP for people stopping PrEP. So WHO, as I said just now, came out with recent guidance that we really need to start early. It's always said within 72 hours, but we're pushing for it to be ideally within 24 hours, however, not later than 72 hours. And I'm wrapping up very quickly. So this WHO came up with 2 new guidelines. HIV PEP should be delivered in community settings. HIV PEP needs to get out of the facilities. We need to look at task shifting and differentiated service delivery. And task sharing should be employed to dispense, distribute, provide, and monitoring PEP. This is an additional approach to providing PEP, We support training, support, and supervision for all healthcare workers, including sensitization on stigma and discrimination, and that providers should be able to offer first-line support to care in line with WHO guidance. And really, and then the last part I really want to talk about is, how to provide PEP. What are the essential elements? Promote task sharing, address legal and regulatory barriers, provide training, support, and supervision, develop quality assurance measures, and last but not least, develop partnerships with the community to ensure services are effective and acceptable. So with that, I hand back to Sarah. Thank you, all of you here in person and online, for joining us. It's really an honor to be here.
Thanks, Mitch. So because we had such a nice big range of papers, and because time is limited here, we're not able to present all the things that were done. So in a typically innovative way that Genesis works, Genesis have put together a really nice video with their animatronic leader, servant, not sure, who's going to introduce it, which is just going to give you some quotes from the different papers that have gone into this supplement. And then after that, you'll have an opportunity here to hear in slightly more depth from 3 of the researchers and the studies that were done. So we'll show you now the video, and afterwards we'll move on to the researchers. The video, please.
Welcome to the Optimizing Africa's PEP Response, from research to reality event, where we launch the PEP in Africa, prospects, opportunities, and challenges supplement for the Journal of the International AIDS Society. It all started with a recent meeting in South Africa, where we engaged in critical discussions with key stakeholders across 5 countries to discuss the updated WHO PEP guidelines, share new evidence, facilitate stakeholder exchange, and contribute to the supplement. Some of the key takeaways were: PEP has been forgotten and historically overshadowed by other interventions within the HIV prevention toolkit. This is despite evidence that demonstrates the effectiveness of PEP as an HIV prevention method. Key barriers limit the availability, accessibility, and acceptability of PEP within countries. We need concerted efforts to address these barriers and ensure there is access to and uptake among those that need it. The next step is for countries to adopt, adapt, and implement the guidelines within their country context. This meeting laid a solid foundation for the supplement. Let's dive into the pivotal insights from the esteemed authors who contributed to it. We developed a modeling framework to predict the efficacy of PEP in a variety of settings, exploring time from exposure to first PEP dose, number of drugs, and the duration of PEP used. Challenges to the generation of effectiveness evidence on new long-acting PrEP products are not insurmountable. Expanding the number of PEP products available could help engage individuals whose needs are not being met by existing programs. Evidence on expanding PEP access through community delivery or task sharing is limited, but generally suggests positive outcomes, feasibility, acceptability, and cost-effectiveness of these approaches. We need collaboration across stakeholders to fully realize PEP's public health potential and propose adapting regulatory models used for emergency contraception to expand access, support provider confidence, enable insurance coverage, and increase product options. As countries update their PEP guidelines, collaborating and sharing innovations will be key. PEP can be cost-effective if there is a high prevalence of unsuppressed HIV viremia in the sexual partner pool, and is most cost-effective for the early exposures within a sexual partnership or a one-off sexual partnership. With increasingly constrained funding, low-resource strategies for PEP scale-up are more critical than ever. This may include integrating PEP into self-care packages, use of HIV self-tests to reduce provider burden, and policy changes to permit PEP distribution among lower provider cadres. PEP awareness among sexually active adolescent girls and young women in Eswatini remains low, especially compared to PrEP. Tailored efforts like youth-led campaigns and integration into youth-friendly health services and other youth-focused platforms could boost awareness and increase effective use of this underutilized prevention method. Our work presents a cross-sectional analysis of PEP awareness, access, and use in Western Kenya, revealing that despite high behavioral vulnerability to HIV, substantial gaps exist in awareness, access, and use of post-exposure prophylaxis, particularly among individuals with lower education levels and symptoms of depression, highlighting the need for targeted outreach and integrated mental health services to improve HIV prevention efforts. A notable HIV seroconversion rate of 2% per year was observed among PEP users, many of whom continued to engage in high-risk behaviors, particularly young males and those with unknown or HIV-positive partners, highlighting the need for enhanced prevention strategies, including PrEP. Despite significant increases in post-violence care services in 14 sub-Saharan African countries from 2018 to 2023, the completion rates of post-exposure prophylaxis among sexual violence survivors remain alarmingly low, highlighting a critical gap in HIV prevention efforts. Making PEP available where survivors of sexual violence first seek help, such as the police, can reduce barriers to time-sensitive HIV prevention interventions while strengthening access to critical health services. Peer-led distribution of PEP among college-university students was feasible and highly acceptable, achieving good uptake. Delivery of PEP and PrEP at private pharmacies in Kenya reached individuals who could benefit, enabled timely access to PEP for clients with recent potential exposures, and facilitated transition from PEP to PrEP among those interested in a longer-term HIV prevention method. In this online PrEP and PEP delivery pilot in Kenya, PEP uptake was 5 times greater than PrEP, underscoring the large unmet demand for PEP and the potential for online pharmacies to fill this gap and reach individuals with time-sensitive HIV prevention. As we reflect on these key insights, it is clear that ensuring access to PEP is a collaborative effort. We must work together to translate research into stronger policies and programs, and ensure they are effectively implemented so that those who need PEP can access it.
Thank you very much, Toby. That was our colleague on our SSLN i2i project who helps us with all of these things. Can I ask our speakers who are here in person to please come and join us on the stage? So we're going to move to the next part where, it's very sad that we can't have all of our authors presenting, but we're really excited to have one of our authors present virtually and 2 here with us in person. So our very first presenter is Professor Caitlin Kennedy. She is the Director of Social and Behavioral Intervention Programs at Johns Hopkins Bloomberg School of Public Health. And we're really excited to hear the findings from her systematic review. So Caitlin.
Thank you so much. It's a pleasure to join you all today. So I'm here to present findings from our systematic review, which is one of the articles in this supplement. And I appreciate the tech team for moving ahead to my slides. I'm so sorry not to be able to be there in person. Great, so thank you. As was said, my name is Caitlin Kennedy. I'm a professor at Johns Hopkins University, and I'm here to present on our article, which was looking at HIV PEP in community settings and by lay health workers or through task sharing. And we conducted a systematic review of effectiveness, case studies, values and preferences, and costs. Next. Thanks. So the introduction, I think, has already been said several times that PEP has been shown to be effective and recommended by the World Health Organization for over 3 decades. However, it remains underutilized as an HIV prevention tool. And in many places, PEP is not widely available outside of hospital settings for healthcare-associated occupational or sexual assault exposures. And so there's been recent interest in expanding, oops, can you go back one? recent interest in expanding the availability of PEP in community settings and offering it by lower cadres of health workers. Can you move the slides backward, please? Okay, you can. All right, thanks. So we'll stay here. So, this experience with so this interest in PEP has come out of experience with PrEP and also ART that suggests that offering it in community settings and engaging a range of providers can expand access and use. So since we're already doing PrEP and ART in these types of models, there's interest in expanding the availability of PEP through these models, and PEP is actually a less complex intervention than these others. And so there's been recent interest and efforts to expand PEP access, but to date, the evidence, or to the date before this paper was published, the evidence for that had really not been synthesized. Next slide. So this is our paper in the supplement. We sought to conduct a systematic review of studies related to the provision of PEP in community settings and by trained lay health workers or through task sharing. And I'd like to thank my co-authors who are listed here from Johns Hopkins, WHO, and UNAIDS who contributed to the conceptualization and analysis of this work, and also to the authors of included studies who responded with additional data and clarifications. Thank you. Next. So we focused our review on two different categories or types of interventions. First, we looked at availability of PEP in community settings, which we defined as non-healthcare settings, including pharmacies, community-based organizations, mobile units, going door to door, et cetera. And then second, we were also interested in interventions where PEP was provided by either trained lay health workers, meaning individuals who have some training but do not have a formal professional or paraprofessional certificate, or studies that focused on task sharing, where PEP was services were provided by lower level health workers. Next. So our inclusion criteria, we looked for studies that were either randomized controlled trials or observational studies that compared our interventions of interest to either no intervention or to other interventions. On the following outcomes listed here, we are interested in quality of PEP services, uptake of PEP, timeliness of PEP uptake, completion of PEP, HIV acquisition, linkage to other services, and also adverse events. And in addition to our main effectiveness review, we also reviewed case studies, which were non-comparative intervention studies, and also studies of values and preferences and cost. Next. So this is the PRISMA flow chart, just showing the complex search and screening process that we went through to do this systematic review. We conducted a comprehensive search of 4 databases. We also looked for conference abstracts. We talked with experts about what studies they were aware of. And ultimately, after this whole search and screening process, 13 studies met our inclusion criteria. Next. So here are the results from the effectiveness review. So for the effectiveness review, we identified 3 studies. The first was the Search Sapphire study, listed in this first line here by Kabani et al. This was conducted in Kenya and Uganda, and this study offered PEP as part of what they called a dynamic choice model of HIV prevention options, which also included PrEP and condoms. And this dynamic choice model was delivered in 3 different settings: in antenatal care settings, in outpatient departments, where it was offered by clinical officers and nurses, and then also in community settings where PEP was offered by community health workers with links back to those clinical officers at health centers. And because of these different models and different cadres of health providers, the Search Sapphire study was considered to meet both of our main research questions for PEP in community settings and by lay health workers or through task sharing. And looking at PEP uptake over 24 weeks of follow-up, this study found that the initial choice of PEP was highest in community settings compared to outpatient departments or antenatal care settings. And over the follow-up study visits, PEP selection remained highest in those community settings. And then in addition, we have found 2 other studies, both conference abstracts reported on studies conducted in the United States, where pharmacists started providing PEP. So we considered this under our PICO 2 of PEP offered by task sharing. And doing retrospective chart reviews, both of these studies found that PEP uptake and completion were higher after implementation of these new models. And the last study there by Lowry et al. Also looked at HIV acquisition and found 2 documented cases of HIV seroconversion before the new intervention and none afterwards. Next slide. We also looked at case studies. Now, these were studies which implemented PEP through either community settings or through task sharing, but they did not provide comparative data to a different model or to before they had started implementation of PEP. As you can see, these studies were conducted in a range of different countries and settings. And across these different countries and settings, including police stations and community-based delivery, pharmacies, et cetera, across these settings, the studies generally found that PEP was feasible and successfully implemented with a range of different types of outcomes measured there. Next slide, excuse me. Then we looked at values and preferences. And here we were really interested in how people who were potential PEP clients or how health workers felt about offering PEP through these different models. So for offering PEP in community settings, we found one study. This study was a cross-sectional survey conducted with sexual and gender minorities who were visiting collective sex venues in New York City in the United States. And in open text survey responses, participants in this survey expressed interest in these venues providing a range of free HIV prevention services, including PEP. And they felt that these services could be delivered in an acceptable way, although they also found some potential barriers, including privacy concerns, negative reactions to the presence of health workers at these sex venues, and also the feeling that they did have access to these services in other locations. Then for PEP offered by lay health workers or through task sharing, you'll see we found 4 different studies that almost all were looking at providers. One also looked at PEP clients. These looked at a range of health providers from a range of different countries, but generally across all of them, they found high acceptability for allowing other cadres of health workers to provide PEP. Next slide. Finally, we were also interested in studies that looked at costs of PEP through these different models. We found just 2 studies that examined costs. The first was a modeling study by Phillips et al. Here that looked at what would be expected to happen under various scenarios of community-based availability of PEP in Africa. And their various models suggested that offering PEP in community settings was almost always cost-effective, depending on the different scenarios considered. And it was actually cost savings in over half of the scenarios that they modeled. And second, we found a study from the United States, which looked at a model of pharmacist prescription of PEP. And it found that this lowered out-of-pocket costs for patients, although it also included free PEP access. Next slide, please. So our review had several strengths and limitations. We did conduct a rigorous systematic review following standard PRISMA reporting guidelines. We did an extensive search, including conference abstracts and contacting experts. And we assessed study rigor and looked at, used the grade process to present data. And all of that's in the article if you'd like to look in more detail at that. However, we also had some limitations. So first, the study only included articles through our search date of October 2023. So more recent articles, including those in this supplement, are not included in our review. However, when we looked at more recent studies, when we were publishing the article, we did not find any that sort of contradicted our overall findings. We also did not look at PEP in pocket, which is another model. It's usually prescribed by clinicians, which is why it didn't fit either of our criteria, but that's another interesting approach that could be used to expand PEP. And finally, our outcomes didn't include PEP medication tolerability, which may be of interest. Next slide. Next slide, please. Thank you. So finally, I'll just wrap up by saying what we found is that research on expanding PEP access through community delivery or task sharing is limited. We would have liked to have found more studies, but that research generally suggests positive outcomes as well as feasibility and acceptability of these approaches. Findings from this review were used to inform the 2024 WHO guidelines on PEP, which Michelle talked about earlier, which did recommend these different interventions. And we think that future research could be very helpful to expand this evidence base to a wider range of country contexts, and also considering diverse needs of different delivery settings and different client populations. So thank you so much for allowing me to join you. Thank you to everyone who contributed to this work. And I'm finished. Thank you.
Thank you so much, Caitlin. We really appreciate your sticking to time and being adaptable online. Continuing with our theme of being adaptable in different times, we're just going to do a little ergonomic change here while we get Catherine up. So if you could just bring the block, thank you. So I'm delighted to introduce Catherine Kiptonis. She is a research scientist from Kenya, and she draws extensively on her experience as a pharmacist to explore HIV self-testing and differentiated service delivery for PEP and PrEP. So we're really excited to hear about your ePrEP pilot. I think they're just bringing something for Catherine, is it here? Yes, thank you.
I think that makes me more visible. All right. Thank you. So I'm pleased to present this work on behalf of the larger ePrEP pharmacy team on the implementation of this study that was done in Kenya. Next. So we are aware of the barriers that are involved in the delivery of PrEP and PEP in public clinics. And we know that in Africa, the e-commerce platforms are expanding rapidly. And this provides an opportunity for us to leverage on this and move PrEP from public health facilities to these platforms, as it encourages increased privacy through the use of HIV self-test kits, the use of telehealth services. Go back, please. The use of telehealth services, longer hours of operation, and also convenience that is offered through this service. Next. So we designed the following care pathway with input from various key stakeholders. And this pathway begins with demand generation that was done through social media and also in-person events. An innovative piece of this component is the telehealth visit, which involves screening for HIV risk, and this was done by clinicians remotely. Clinicians would use existing screening tools to screen for HIV, and also a medical eligibility assessment using a prescriber's checklist. The other innovative piece of this component is the courier delivery of HIV services and also of PEP and PrEP. So clients would have the option of determining where they want these services delivered. Clients who used a HIV self-test kit would upload the results onto a portal, and only after the clinician had confirmed the negative test result would they be delivered, would they be given PEP or PrEP. And this courier service was offered by a registered pharmaceutical technologist. Next. So this was a prospective study that was done in 2 counties in Nairobi and Mombasa. Clients had to be 18 years and older and did not have any contraindications to taking PrEP. The commodities were provided for free by the Kenya Ministry of Health, and the HIV self-test kits were subsidized. Surveys were administered at 3 time points for those on PrEP, and a one-time questionnaire was administered for those on PEP. The outcomes included PrEP and PEP initiation, PrEP refills, PEP to PrEP transition, and also implementation outcomes. Next. So this is just a photo showing the various moving pieces that are involved in the delivery of this delivery model, including where the drugs are gotten, the telehealth call center, the dispatching PharmTech riders, and also the pharmaceutical technologist courier. Next. So we screened 2,257 clients, and we had 1,915 clients who were determined as preliminary eligible for either PEP or PrEP. And of this, we noted that 80% of these clients were PEP clients. In addition, we also saw a very high uptake of PrEP and PEP, with more than 92% of clients getting either a 30-day supply of PrEP or a 30-day supply of PEP. Next. We also looked at the demographic characteristics of clients accessing these services, and we saw that a majority were older than 25 years, and they were male. Few reported being married. Most were either PrEP or PEP naive, and most reported higher education level than general. Next. We also looked at behaviors associated with HIV risk, and we found a majority of PrEP and PEP clients reported that they had partners of unknown status, inconsistent condom use, and multiple sex partners. When we also looked at PEP clients, next, we know that initially when PEP was rolled out, it was intended for HIV exposures due to occupational risk or sexual assault. However, in our study, we found that about 93% of PEP clients reported that HIV exposures were sexual. Next. We also wanted to look at the PrEP continuation and PEP continuation outcomes, and we found that PrEP continuation was low among this population. We also looked at, please go back, we also looked at PEP continuation, and we found repeated PEP use and also low PEP to PrEP transition at 6%. Next. We also wanted to understand what motivated PrEP transition, and we did a multivariable regression analysis, and we found that married individuals were less likely to transition to PrEP, while men who have sex with men, having prior PEP or PrEP use was associated with more likely transition to PrEP. Next. We also wanted to look at the efficiency of delivering this model, of delivering PrEP and PEP with this model. And we found that a quarter of the clients access these services after working hours, showing that online pharmacies can reach clients who may be unable to access these services from routine public health HIV clinics. Additionally, we saw that the use of HIV self-test kits within this model was feasible, as we had more than 80% of clients who were able to successfully upload a HIV self-test result. With this online pharmacy model, we also saw that more than 96% of clients received PEP within 72 hours of exposure. Next. We also looked at some implementation science outcomes like satisfaction with the model, and overall, clients reported high satisfaction with this model. Next. Clients also reported high acceptability of this online PrEP and PEP delivery model. Next. In conclusion, our study showed that online pharmacies are a promising platform for the delivery of PEP and PrEP, offering services that are feasible and acceptable, and reaching a unique group of clients who may not traditionally access care in health facilities. For example, men, and also men who have sex with men. Next. Please go back. Thank you. So what we found surprising was the high uptake of PEP, which was 5 times higher than that of PrEP. We also saw some repeat PEP use and low PEP to PrEP transition. This was high despite not doing any demand generation activities for PEP. This emphasizes that there is a population out there who may want to use PEP as a HIV prevention option, and that there are people who are interested in HIV prevention products that are periodic versus persistent. Additionally, online PrEP and PEP delivery can successfully reach PEP clients in a timely manner. In conclusion, our findings emphasize the need for choice in products and delivery models within HIV prevention programs, and the role online pharmacies could play in facilitating this. Next. I would like to thank the co-authors, the implementers, and also the event organizers for allowing us to do this work and to share this work. Thank you.
Fantastic presentation. Thank you so much. And so exciting to see these different and innovative models. I'd like to introduce our next speaker, Opa Kagoyo. Opa is an early research scientist at SESHA in Zimbabwe, and she's passionate about all things SRH and HIV prevention. She's going to be sharing her findings from a study to promote HIV prevention and contraception services at universities in Zimbabwe.
Good afternoon, everyone, and thank you for this opportunity. Please, can you go to the next slide? Thanks. So my name is Opa Kagoyo, as indicated by Sarah, and I'm just going to give a brief talk about developing and evaluating a community-driven intervention to promote uptake of HIV and contraception services among young people in Zimbabwe. Next slide, please. Young people do not optimally take up HIV services, and this is particularly concerning in sub-Saharan Africa, where HIV is endemic. If you look at the figure, it illustrates the trends in people. It's a figure that was generated in a modeling study that was looking at trends in people living with HIV in sub-Saharan Africa who are aware of their HIV status. And what we can see from this figure is that the 15 to 24 years group has always been significantly lagging behind. And this is particularly concerning because young people in Africa are most at risk of contracting HIV. The recent UN AIDS report that was published last week indicates that 28% of all new HIV infections were recorded among young African women. And more than 80% of sexually active adolescents in sub-Saharan Africa are not using contraception. And this leaves them at risk of contracting, of developing unintended pregnancies, dropping out of school, as well as unsafe abortions. So these alarming statistics indicate that we need interventions that can promote uptake of HIV and sexual and reproductive health services among these young people. The study I'm describing today is following from the successful implementation of a peer-led distribution model of HIV self-test kits that were distributed to students at colleges and universities in Zimbabwe. From this study, the students indicated that they wanted a more comprehensive package that included HIV prevention and contraception services in addition to the HIV self-test kits. Next slide, please. So in response to this, we co-developed this intervention with the students, Ministry of Health, Ministry of Education, implementing partners, as well as the Medicines Regulatory Authority in Zimbabwe. We finalized this intervention and then proceeded to pilot it at 3 tertiary education facilities. We selected institutions that had a maximum enrollment of 3,000 students and also institutions that had participated in the previous HIV self-test kit pilot. We evaluated our intervention by analyzing program data, conducting qualitative studies, and costing analysis. Next slide, please. So the model of distribution for our intervention was a peer-led distribution model. During co-development, the students indicated that they wanted all the commodities on offer to be directly distributed by the peer distributors. But because of regulatory restrictions, this was not possible. So we agreed to have a model that would allow peer distributors to provide HIV self-testing kits, condoms, as well as vouchers which the students could use to go and redeem for PEP and emergency contraception at the institutional clinics. We documented uptake of services using mHealth and paper-based records. And we implemented our intervention over 1 month at each institution. Next slide, please. So the first institution where we implemented was a polytechnic college that had an enrollment of 1,200. The second was a vocational college with an enrollment of 800. And the third was a university that had an enrollment of 2,220 students. It's also worth noting that although these clinics technically offered condoms, none of them had condoms in stock during the time of implementation. Next slide, please. We used Proctor's framework to evaluate the intervention. We collected program data, and this was used to assess for outcomes such as acceptability, adoption, and costing. And then we also collected qualitative data, which we use to obtain thematic areas on acceptability, adoption, appropriateness, feasibility, and fidelity of the intervention. Next slide, please. So we approached 17 students to become peer distributors within the intervention, and all 17 agreed to participate. 14 of these students implemented the intervention successfully as peer distributors. 473 students took up male condoms, 107 students took up female condoms, 616 students took up HIV self-test kits, 100 students took up PEP vouchers, and 30 PEP vouchers were redeemed. 257 students took up emergency contraception, and 104 students redeemed their emergency contraception. Next slide, please. Although not significant, we found that males were more likely to redeem PEP than female students. Next slide, please. We also found that males were more likely to redeem emergency contraception vouchers, and it was statistically significant. We found that students from the vocational college were more likely to redeem emergency contraception, and this was because the clinic for the vocational college was located off-site, and it was a discrete location for students to redeem. Next slide, please. Across all data collection methods, we found that there was high acceptability of the intervention, and this high acceptability was driven by the fact that there was acknowledgement that students were at risk of contracting HIV. Students reportedly engaged in condomless sex with multiple partners. They engaged in transactional sex. They engaged in sex while intoxicated. And they also cohabited with their boyfriends or girlfriends in what they termed semester marriages. In these semester marriages, condom use was equated to partner distrust. Our intervention offered PEP for immediate use, but what we found was that students were also collecting this PEP and keeping it for future use. The students indicated that they wanted to ensure that they had PEP all the time because their tomorrow was unknown to them. Next slide, please. Another thematic area that was recurrent across the study was the moral judgment on premarital sex, and this was from a societal perspective. Female students were less likely to redeem PEP and emergency contraception, and this was because they didn't want to be known to be sexually active. Students that went to redeem their PEP and emergency contraception from the clinics experienced negative attitudes from the healthcare workers. Some of the healthcare workers tried to shame them or make them feel uncomfortable, and all they were saying was, you might actually deserve to contract HIV because you're engaging in unprotected sex and you're also having sex outside of marriage. We found that there was stigma around PEP, which was more pronounced than emergency contraception. Particularly, the students learned that PEP was made from antiretroviral drugs, and they didn't want to have anything to do with it. So they just went to redeem their emergency contraception and protected themselves against pregnancy alone. Next slide, please. It cost $42,205 United States dollars to implement the intervention across all 3 institutions. And that translated to $14.57 for the cost per student exposed. We also calculated the cost per total student enrolled at each of the 3 institutions, and this came down to $10. Next slide, please. Peer-led distribution of PEP, HIV self-test, and emergency contraception is acceptable, feasible, and affordable. And what we found was that this peer-led distribution model was an important way for young people to get access to these services that they need. However, there's need to address the barriers so that we can increase uptake of these services among young people. Firstly, the students indicated that they wanted their PEP and the emergency contraception to be made available through the peer distributors. However, due to regulatory restrictions, this was not possible. And secondly, we found that the students were collecting PEP for future use, which is PEP in pocket. PEP in pocket is also something that's not allowed in our regulations in Zimbabwe. So I'm here to implore the policymakers in Zimbabwe to look at the current regulations for PEP delivery so that we can allow for community-led delivery as well as PEP in pocket, which is something that might increase the uptake of these services in line with the WHO guidelines. There's also need to ramp up on education and awareness campaigns so that we can debunk the stigma and the negative healthcare worker attitudes that were experienced in this study. It's important for us to look at our young people and empower them so that they can take control of their own health towards reaching universal health coverage. So self-care packages such as these are very important and they're needed for these students, but they need to be underpinned with youth-friendly health clinics so that they can be successful. We're conducting a larger randomized control trial of this intervention, and we hope that this can improve the uptake of services among young people. Next slide, please. I'd like to acknowledge UNA as our funder, as well as the organizations that are listed and the individuals, and I'd like to thank you for your attention.
Thank you so much, Opa. That was a fantastic presentation, and I really loved the call to action. I think it's very much in line with the title of today's event about moving research, from research into reality. So thank you for that. Colleagues, we are going to have time for Q&A after the next session. So I'm going to ask our authors to move back into their chairs and ask the audience for one more round for our authors both here and not here, as well as our three amazing guest editors. So thank you. Our next part of the program is really what the South to South Learning Network and Insight to Implementation is about. It's about taking the research and making sure that we turn it into reality and allowing countries to do so and to learn from each other. So I'm delighted to introduce our facilitator, Mohammed Khan from SSLN i2i, where he is the Southern Africa Regional Lead. And I'm going to ask my colleague, Dr. Daniel Boyamukama, who is the head of HIV prevention at the Uganda AIDS Council, to come and join us on stage. I'm also going to introduce two other colleagues who are with us virtually. We've got Chris Obermeyer, who leads the global fund work on PEP and PrEP, and Morris Mugudha, who is a PEP provider and clinician in doing so in Kenya. So thank you.
Good afternoon, everyone. Thank you so much for making the time to be here for this important conversation. We know that with the South to South Learning Network and Insight Implementation teams, we really want to make the innovations that are out there in the world meaningful and useful to the constituencies. Particularly, we need to engage with the right people, and that's the aim of this panel. We want to make sure that you hear from the level of government, community implementer, as well as donor about the value of using the PEP guidance and the WHO guidelines effectively. So I'm going to start off by asking Dr. Daniel the first very important question on our side. So Dr. Daniel, being a big advocate in the HIV space and supporting the government of Uganda with a number of HIV interventions, I want to ask, building on the updated PEP guidelines, as well as the new Research to Insights PEP in Africa supplement, how can governments incorporate these findings and recommendations into national strategic plans and other government plans?
Thank you. Good afternoon, all of us. So as introduced, I'm Daniel Boyamukama. I'm from Uganda, the Uganda AIDS Commission. And I already told you I'm an old man. I've been working in the HIV space for quite some time. I have personally ever taken PEP. I almost completed the dose. I think I missed by like 2 days. So you can clap for me. I did 26 up to 28. Data from Uganda shows that a very small percentage, less than 5%, complete PrEP. Data from Uganda also shows that more than 48% of the people we have in the HMIS start PrEP after 72 hours. I started mine within time. So you can imagine 48% of those on PrEP started late. I don't know why the clinicians go ahead and prescribe. But what is shared in the WHO guidance is common sense, makes sense. What our colleagues have shared, it makes absolute sense because we have not benefited from PEP as we are capable of benefiting. When I look at our HIV epidemic and I see the new HIV infections, they still occur in the general population. Among the moderate risk, the key populations, the very high risk contribute only 11% of the infections. So the moderate risk, one of mistakes that young people make, even adults make, which can easily be prevented either by condom or PrEP. Condom has its own challenges. We are not maximizing PrEP. So how do we move forward with these important findings? Number one of the researchers presented talked about policymakers, called out the policymakers in Zimbabwe, in her country. And when you think of policymakers, most people think the policymakers are actually members of parliament seated there or cabinet. The policymakers are actually us. Cabinet approves just out of the bureaucracy, but the policymakers are actually the people on the call. It is me. If I decided to put what you have written here, I will put it in the policy and I will take it to cabinet and they approve it. If I don't do that work, so the researchers, I often go with the researchers, find them addressing the policymaker, and they are thinking about a member of parliament. He does not have the time to do this policy. It is me who will do that policy, and he will do the ceremonial passing. Of course, there are some political thorny issues he may edit out, but common sense things like this, they often pass. So it's a call. All policymakers, all leaders of the response in the country, these are common sense findings that we should take on. But I think there is a role for SSLN now. Can you take this information to as many of the policymakers as the pseudo policymakers, the people who will draft the policies? Let the information be disseminated widely to the key technical leads, and this work will be done. It makes common sense. Number two, the work emphasizes task sharing and going to the community. This is an area that is not novel. We have done it with other programs, but not without resistance. I remember when we started PMTCT programs and we wanted lay counselors to take on HIV testing, the resistance was stiff. It was almost impossible in Uganda. I traveled from Uganda in 2006 to visit Malawi. ARV in Uganda at that time was only prescribed by a physician or a senior medical officer. I reached Malawi, I found clinical officer, nurses were prescribing ART. So I called home, I said, no, okay, why are you really limiting people from accessing? So there is always resistance, there is always lack of trust, trust of the communities. And I think this is an area that we have to address. The colleagues presented about stigma. There is so much stigma. Everybody told that I actually took PEP. It was during surgery, a needle stick injury. I had been called to deliver a wife, a woman, a mother, who had severe genital warts. I said, I cannot let the baby pass here. So I said, take her to theater. But I punctured myself. But everybody I tell, I feel like they are indirect telling me, oh, you made a mistake, Dan, you did something wrong. So even when I was getting the PEP, so the young lady, what she talked about, this stigma is there. And stigma is something we have created. So I think it calls on communication, the communication strategies to address stigma within our communities, stigma towards PEP. I liked her appeal, one of the speakers, because when you look at PEP, it's an emergency. If it is your child who has been accidentally exposed, you would call every doctor friend to get PEP. But if you're a clinician and it's somebody's child, then you have the pressure of judging her. So I think the wording in our frameworks must emphasize the emergency, that it's an emergency, we are saving a life, it could be a child's life. If it's your child's life, I'm sure it's an emergency. And that wording should come out in the frameworks we do. The development of strategies that you talk about is a multi-sectoral effort. It's not led by just me, by public official. All stakeholders who are equal partners, including civil society, including communities, including development partners. And I want to start with civil society and communities. We often give emphasis to what they emphasize. The voices of communities and civil society, when it comes to PEP, they have been a bit silent. So our platforms to engage civil society and build their capacity, to hold us accountable, to demand, they also need to be activated. Channels through, I could see civil society, they were very vocal. when it comes to things like the vaginal ring and cannula, and we are quick to approve the vaginal ring because there was pressure from young people, from civil society. But there's no, and the process of developing the strategic plan is consultative. So we often capture what the communities tell us they will take on. So the civil society, they need to come forth. The communities need to be empowered to demand better PrEP now. I also wanted to emphasize development partners. As much as I was happy with the news Peter shared, that PEPFAR is still around, I have been part of the process of developing the sustainability roadmap for the country. And with all the permutations, there's no question we still need development partners. So we are glad for the news from PEPFAR. But when I read the PEPFAR COP for the current COP, I compared the word PEP and PrEP. The word PEP appears 12 times. The word PrEP appears close to 200 times. So our development partners have a way of skewing things and giving importance to issues and ignoring others. So as we advocate with WHO for these issues to be taken up, we need to advocate with our development partners, give them this evidence so that they put it among their high priority. Of course, I'm being told time is running out. I need to emphasize, like one of the presenters said, there are several unanswered questions. When you look at research, I looked at research in hospital settings, doctors or nurses who had got occupational exposure. A good number of them will not start PEP. What are the questions there? We have talked about low completion rate. 5%, there are unanswered questions there. So we need to do some research to answer some of these unanswered questions. I have two last points. The last one is about accountability. I have seen, as work with the Global Prevention Coalition and the scorecards the UNAIDS produces, there is a way they compare countries to implement such innovations, to put these innovations in practice. So I would want to score upon, it's a GPC, we're developing a new aid strategy, we're developing a new 2030 roadmap, a new scorecard. I think we should put this achievement, updating PEP guidelines, taking PEP to the community where it really belongs as part of the scorecard. That will compel us actually to act and implement the policies. But of course, there are real challenges. The challenge of over-PEPing, because most of the drugs we use for PEP were mainly part of the LT program. We factor in something small. So the over-PEPing and the burden of the cost, which is going to be a real challenge for the policymakers, and of course, in addition to the stigma. Even the stigma, we are seeing it with Kabla and Nakapavir. People are saying, aren't you going to promote promiscuity? But the communication will take care of that. And we hope, well supported by our partners, these guidelines will be put in practice within our countries and bring PEP closer to the people so that it can play a better role than it's currently playing. Thank you for listening to me.
Thank you so much, Dr. Daniel. As you can see, Dr. Daniel has many great insights and ideas. And please, if you have questions, I'm sure he will be first on the Q&A block, but also afterwards. Next, I'm going to move on to Maurice so we can hear about the community implementation level. Maurice has extensive experience at that level and has worked with communities quite closely. He's located within Nairobi County in Kenya. Can I just have on our internal screens, Maurice come up? And in the meantime, while that's happening, Maurice, I want to just ask the simple question: what are the most significant community level barriers to PEP access and completion? We know that the supplement as well as the guidelines have some great ideas, but moving this into the practical sphere is very important. So how can we overcome these barriers and improve PEP acceptability and adherence within the communities? Over to you, Maurice.
Okay, good afternoon, everyone. I'm Maurice Maguda, as I've been introduced. I'm a clinician. I work at in Nairobi at actually the facility that had the first patient tested of HIV in Kenya in 1982. Now, just as Dr. Biamkama said, I concur that there is a problem with PEP and PrEP completion rates. and that is one of our top undoing in service provision about PEP. So the biggest gaps in our society is not actually evidence of PEP, but lack of awareness and confidence in the system to deliver it efficiently. Where the studies that support PEP delivery in community settings often find that clients, especially survivors of sexual violence, stigma comes up. Then there is element of fear post-exposure and delays in accessing care within the stipulated time of PEP initiation. So we need to enhance information dissemination in the communities at community level, and usually including behavior change counseling, which will also involve behavior change champions, and critical awareness on PEP and PrEP, because most people in the community believe that PEP is specifically meant for healthcare providers. So the information about availability of PEP to the community is also very limited. So we need to enhance working on that going forward, and that one will significantly improve PEP uptake in our communities. So there is the element of awareness. It's more in urban areas than in rural communities. So the reason why maybe we could say there is awareness in urban communities, that's where we can say the elite mostly are people who are educated, and they can easily access information. Like we have information over the internet and it can be accessed at any point. But now the element of fear is the biggest driving factor here, where we'll find someone got exposed a few hours ago and runs the hospital at night for the post-exposure prophylaxis. So about completion, there is very little data that shows that someone has completed. In most cases, just as Dr. Biomkama said, he missed completing in maybe 2 days or so. That is actually what also happens on the ground. Not all of our clients complete the treatment session. So on emphasizing on completion, we need to involve healthcare promoters in our society. We have healthcare promoters who are actually educated, and they can also still be involved in more education on adherence and referral from the communities, and also raising more awareness on HIV transmission and availability of PEP, and also the effectiveness of PEP, so that people in the communities can also understand better. So their involvement only works when they are trained on PEP indication and follow-up requirements. Data collection, they should also be put in the forefront on ensuring that people who are enrolled in PEP regimes actually complete, either by taking the medication to them, or following up with the pharmacists on the ground, or getting them back to the hospital for completion. Then there's also an element of PEP and PEP to PrEP conversion. There is also very limited numbers of people who are enrolled in PEP getting enrolled into PrEP for continuation of prevention. So we need to enhance systems. We need to enhance systems that allow rapid linkage to care. This will also come in basically on information dissemination to people who are exposed and who are in use for PEP. So we need to produce simple job aids, produce simple information education materials that can be easily available or rather disseminated to the ground for people to read. We need to enhance refresher trainings for medical practitioners, the clinical officers, or rather clinicians, the nurses, the peer educators, and also those ones who are in this context, the community health promoters or volunteers. In some contexts, they are called so. So we have platforms. Electronic platforms can also be enhanced to monitor them. For example, we can have innovative solutions in digital platforms.
Sorry,
Like we can
just give you a few more seconds so we can also have time for the Q&A, okay? So your last thought very quickly.
Yes, digital solutions. We should also enhance that one so that we can have online reminders and follow up. So otherwise, I think we are doing well, and enhancing the same will actually improve the uptake and the positive outcomes in our communities. Thank you.
Thank you so much, Maurice, for that. Those are great insights. And I think those really pull it down into the community implementation level. A lot of messages which are great facilitators to making sure that PEP is out there and available to people that need it most, and also the clinicians and all those that support the system are also involved in this journey. For our last panelist, I'm going to call on Chris Obermeyer. Chris has over 13 years of experience across 70 countries and quite a lot of work in HIV prevention. They are a senior advisor for PEP and PrEP at the Global Fund, and they lead a number of strategic directions and insights. I think this will be a very interesting component to this topic. For Chris, I have the very simple question of asking, how can donor organizations strategically leverage the learnings and findings from the PEP supplement as well as the WHO guidelines? And in particular, how can they be applied to vulnerable populations and even key populations? Over to you.
Yeah, thanks so much, and thanks for having me. So I think there's a number of things that donor organizations can do. One, I really appreciated colleague from Uganda kind of comparing the number of mentions of PEP and PrEP, and that's something that we've been very mindful of in our Grant Cycle 7 information note, of making sure that people can see that we don't see PEP as this thing that's only for instances of sexual violence or occupational exposure, but we see this as a key component of the overall HIV prevention package. And so we were very intentional in making it part of our program essentials. I think alongside continuing to kind of elevate it and see it as part of the HIV prevention package, I think we have a role in leaning on our technical partners such as WHO and getting that guidance and supporting countries to actually adopt and uptake that. And that's why I had a question in the chat that maybe we'll get to later for the colleague in Uganda. I think also, the role that we have is as donor organizations, is to support countries in doing what is necessary to do many of the things that Maurice mentioned in terms of, funding training for providers, funding efforts to make sure that demand creation things don't just talk about condoms and PrEP, but also talk about PEP as part of that package. I think we have a huge role in kind of expanding choices. We know from family planning that when people have a number of choices available to them, that they're likely to pick one of them, right? And I think that applies really well here, and that, if people's options are condoms, well, it's going to be condoms or nothing, right? And when there's PEP, and I think for too long, our efforts around PEP have really been focused on sexual violence. And in my opinion, I think there's been some kind of actually some negative work that has kind of happened with that, and that you actually have a number of people who are experiencing sexual violence, but we also know that sexual violence reporting is super, super low of those and so what actually ends up happening is when you have PEP mentality that is only for people who experience sexual violence, the people who need it but can't disclose that to others, to their healthcare provider, to the community member, are actually kind of barred from access. And so well-intentions have actually prevented people from being able to access these services. I think going to the kind of wider access, I think it's really important that we make sure that programs for sexual violence, occupational exposure continue to have PEP as a key component. And we also need to make sure that we expand that so that everyone sees that as part of it, because not everyone who needs PEP actually needs PrEP. It may be that they use condoms consistently or they have infrequent partners. And so we need to see it as another tool that people might use for some periods of time. They might switch to PrEP. They might have another partner that they use condoms with. And so we need to be, I don't know how to say it other than to say we need to be human and recognize that like everyone is different and that their lives are complex and nuanced. And by providing these tools, we can really do that. And so as donors, I think we have a role in funding these tools and methods that we know really work, and making sure that we also put in things so that we can actually track that use, or track actually uptake and accountability. And so, one thing we did in our current grant cycle is we actually made it so that TLD, which is the primary drug used for PEP, was not just something that was kind of looped in with ARVs for treatment. We actually differentiated that so that we could see that PEP was actually being procured for the purpose of PEP. And that actually allowed us in our technical review panels to say to countries when they didn't have it, hey, who's buying the PEP? Because we know that it's necessary. We know it's a vital part. And we saw that through this grant cycle, a lot of countries actually were like, oh, how do we quantify this? How do we do this? And so there's a number of questions around quantifying that I think we need support from technical partners to do, as well as countries who have lots of experience with this. But donors doing those sorts of things actually can move countries to actually investing in PEP in a substantial way. And so we're going to kind of continue to do those things because we continue to see PEP as a really, really key part to this kind of overall package. Yeah.
Thank you so much, Chris. Okay, now we are moving into the Q&A portion. So there is a roaming mic here. I'm going to start first with if there is anyone in the audience that has a question for any three of our panelists, please do let us know. There is Sean, and then I think there's the lady in the front as well.
Thanks, folks. Maybe a question for the colleague in ministry. My understanding is that there's not a risk of drug resistance if you take a course of PEP and are already living with HIV. What then is the basis for this very strict regulatory approach of needing to go through a whole series of steps before we'll allow someone to have PEP? Is there some other risk that we're not considering there?
Could you just repeat that one more time, Sean? I think you were asking about the regulatory hurdles.
Yeah, it's basically why are we making, what is the risk in making PEP more freely available versus having folks go through a set of steps to be eligible for it?
Okay, let us take one more question and then we'll move on to the responses. Okay, please go ahead.
So my question is for the HIV self-test that was used in the online PEP. Did they have to upload a photograph when you said you were submitting results? Because we're kind of trying to use self-tests more, and I wonder if it's making it complicated, requiring the upload of results, or can we just believe a text that it was negative?
Okay, great. Dr. Daniel, are you ready to answer? Oh, I'll check the online as well. Although just for brevity of time, I think we'll only do a few questions over here. People can mingle and then we'll address the others online as well as we go on, okay? Yeah, please go ahead.
Thank you. Thank you for that question. There is a theoretical risk that when we make PrEP so available in a community, there will be, it may not be theoretical, there will be resistance. But even if there was no PEP, resistance still comes. So we cannot let a few people contract HIV so that we don't get drug resistance. Whenever drug resistance comes, we always have another solution. So I don't think it is fair. But there are ways to mitigate that. For example, if we take it to the community, we have self-testing kits now. It goes with self-testing kits, which reduces, and most of them are accurate, which can remove the risk significantly of starting people on treatment or PEP when they are already HIV positive. Significant risk. Actually, I saw in our data a significant number of people who, like 8%, who come looking for PEP. 8% are HIV positive. So the risk is real. But I believe the HIV self-test kit can become part of the kit that we present to the community and eliminates that risk. But at the same time, even though there's no self-test kit, I think it is not fair to let somebody contract HIV so that we don't develop resistance. So we will find another drug if the resistance comes.
Thank you, Dr. Daniel. If there are...
I don't know, I see Prof. as if he wants to add something to it.
Yeah, just handing the mic over for that last question.
Thank you for your question. So yes, we did require them to upload a photo of the HIV self-test kit. And it's because this was a study, so we had to get special permission because HIV self-test is not standard of care for you to be able to start PrEP or PEP. So it was a requirement for them to upload the photo, then have it verified by a clinician that they were actually HIV negative. But you bring up a good point that at the point of scale up, maybe that needs to be simplified so that policies change to allow the use of HIV self-test kit for one to be able to initiate PrEP or PEP. Thank you.
I think one of the issues sabotaging our PrEP program now, it is that fear that when we take out we liberalize the program, we take it out of the hospital, then there will be resistance all over the place. The community, it's a lack of trust, failure to trust the community that they will do the right thing if they are well trained and quality assurance mechanisms are put in place. It's a lack of trust.
Thank you, everyone. I don't think we have enough time for the last question or comment, but we are all going, for those physically over here, please do make use of the space and talk to each other. Thank you so much for the panelists and all of the questions. I'm going to hand back over to Sarah. Thank you all.
Okay, thanks everyone. As Mo says, those of us here in person, let's please network after this and ask everyone some questions. Those of you online, we'll make sure that we post something afterwards, getting back to you on your questions. So I'd like to introduce our last panelist, Yvette Raphael. She is the Executive Director of Advocacy for Prevention of HIV in Africa and an old friend, and I'm excited to hear what you have to say.
Thank you so much. And for once, I'm on the stage invited and I'm not making trouble. Thank you. I think my first thoughts as Sarah and her team invited me here was, why are we still struggling to see the importance of PEP when it's one of the oldest HIV prevention methods that we have? And also the least used, but the most stigmatized. And I think I cannot repeat what some of the panelists have said here, is that we should really think around how do we get community behind this work and not keep it as papers, some of the things that we do as presentation. I'd really want us to see the PEP work in our communities, and communities have done a lot for PEP. I remember at first, we were so behind getting PEP to everyone while healthcare workers were struggling with what does it mean? Is it for gender-based violence victims only? Is it only for people who have, who come to the clinic and have this weird story to tell? And I think community worked behind that to ensure that we all understand what PEP is. But also, I want to share a story way back in 2007 when HIV prevention was not fashionable and everybody was just scared to get infected because either your partner uses a condom or not. And a friend of mine came to me and said, something happened, the condom burst, and the nurse sent me to go and do a story about gender-based violence, but that was not the case. And I said to her, if you have money, find yourself a doctor, ask him what the medication was that actually would prevent, that he would prescribe to you without the GBV story. Sell anything and get yourself the medication. And she did exactly that, sold her TB and is HIV negative. And we all later found out that the person that she had a mishap with was HIV positive. So the power of PEP is not something new. However, I just don't think we put enough emphasis on it. And PEP has the power to really avert a lot of new infections, especially amongst young people. I know there are young people in this room, and when I saw PEP in pocket, I can just imagine how revolutionary that can be. I think we over-medicalize some of these things. I still want somebody to tell me or to come up with the results that, and maybe I shouldn't say it, but do we really need all 30 days? Is the science there? Do we really need all of them? And young people really tell me that I only took, but I can't say that here. There will always be pushback and resistance to new ideas and ideologies. But I also want to say sometimes the healthcare system can be and is the barrier to HIV prevention, and many young people still say that. So we need to think around. I want to go back to what Sean says. Really, do we really have to over-medicalize it? I switch off when a presentation say, but community will abuse this, community will. That's 5 or 6 cases out of the millions of lives that we can really avert from getting HIV. So I think let's bring this back into the community. The papers say, take it to the community, but I'd like to hear Sarah and really challenge you and your organization to say, let's have a community discussion around this. How do we really make sure we advocate for it? When we talk choice, PEP is not in that basket, and it is a real, real disaster if we don't try and do something about it. Thank you so much, everyone.
Thanks, Yvette. I think that is the first time that I've ever been to a presentation where you haven't caused too much trouble. So thank you so much, everybody, for coming today. I think we've heard about the really amazing new WHO guidelines. We've heard from some of our researchers, and I think a great call to action about ensuring that we take that research and make it a reality by involving communities. So thank you, everyone. Those in the room, please make sure you sign the register. Go and have a drink, mingle. Let's talk all things PEP. Thank you.